Two patients can both have a cervical length of 22 millimeters, and yet the correct medical conversation may be different. One patient is a singleton pregnancy, asymptomatic with no prior spontaneous preterm birth, scanned at 21 weeks. The other patient has already delivered spontaneously at 28 weeks in a previous pregnancy, and now the same cervical length is found later. The ultrasound number is identical. The clinical object is not identical. That is where this course begins. Not with a drug, not with a recommendation, with the discipline of naming the object of care. When we talk about medical prevention of early delivery, the first question is not, does short cervix get progesterone? That question is too crude. The first question is, what phenotype is this? At what gestational age was it detected? And which endpoint are we trying to prevent? Those three words should become the resident's first reflex: phenotype, timing, endpoint. Phenotype means the patient population. Is she asymptomatic or is she contracting? Is this a singleton or a twin pregnancy? Are membranes intact? Is there cervical dilation? Is there a previous spontaneous preterm birth? Has she already had two very early births? The same cervical length can live inside different phenotypes, and evidence belongs to phenotypes. Timing means the gestational age at which the risk signal is found. A cervix found short at 21 weeks is not the same evidence situation as a cervix first found short at 28 weeks. Timing is not decoration. Timing determines whether the patient stands inside the randomized trial evidence window, near its edge, or outside it. Endpoint means what outcome the study or guideline is trying to prevent. Preterm birth often means birth before 37 weeks, but a birth at 36 plus 5 and a birth at 27 plus 5 are not the same biological or neonatal event. Many trials therefore use earlier thresholds, before 34 weeks, before 33 weeks, before 32 weeks, or before 28 weeks. Other studies ask a different question. How many days were gained? What was the mean gestational age at delivery? Was neonatal morbidity reduced? The phrase early delivery is therefore incomplete until we define it. This matters because cervical length itself is not a cliff. The classic anchor is the IAM study from 1996. Cervical length was measured at 24 weeks, and the risk of spontaneous preterm delivery before 35 weeks rose progressively as the cervix shortened. At or below the 10th percentile, which was 26 millimeters, the relative risk was about 6.2. At or below the 5th percentile, 22 millimeters, the relative risk was about 9.5. At or below the 1st percentile, 13 millimeters, the relative risk was about 14. The important memory is not just the numbers. The important memory is the shape of the relationship. The cervix behaved as a continuum of competence. The shorter the cervix, the higher the risk. That is why a cutoff such as 25 millimeters is useful, but it is not a biological cliff. So how should the resident store 25 millimeters? Store it as a risk and guideline boundary. It helps identify the short cervix group. It does not mean that 24 millimeters is disease and 26 millimeters is health. The IAMS data should protect you from that kind of false binary thinking. Now add the next number, 20 millimeters. 20 millimeters is different. In Society for Maternal Fetal Medicine Consult Series number 70, for an asymptomatic singleton pregnancy without a prior spontaneous preterm birth, a transvaginal cervical length of 20 millimeters or less before 24 weeks is the stronger recommendation zone for vaginal progesterone. A cervical length of 21 to 25 millimeters is not ignored, but it becomes a shared decision-making zone. So the memory is a pair, not a single number. 25 names the risk signal. 20 is where the recommendation becomes strongest in that specific asymptomatic singleton phenotype before 24 weeks. Now listen to how endpoint changes the conversation. 37 weeks is the broad preterm birth boundary. It is useful for public health, birth statistics, and recurrence counseling. But many prevention trials care deeply about earlier thresholds because neonatal risk rises sharply as gestational age falls. Fonseca's trial used spontaneous delivery before 34 weeks as the primary outcome. The pregnant trial used preterm birth before 33 weeks. Meta-analyses often report before 34, before 33, before 32, and before 28 weeks. Do not let those thresholds blur together. Each one asks a different clinical question. Before 37 weeks asks, did the pregnancy reach term? Before 34 weeks asks, did we avoid early preterm birth, where neonatal morbidity becomes more serious? Before 28 weeks asks, did we avoid the extreme preterm zone, where each week is profoundly consequential? This is also why time to delivery matters. A treatment may not convert every patient from preterm to term, but if it moves delivery from 28 weeks to 31 weeks, that can be clinically meaningful, even though the birth is still preterm by the under 37 definition. Conversely, a reduction in birth before 37 weeks can be less impressive if it does not move severe neonatal outcomes. By the end of this course, you should be uncomfortable with an unqualified sentence like progesterone prevents preterm birth. You should want to ask in whom, started when, by which route and dose, compared with what, and for which endpoint.
Return now to the two patients with a 22 millimeter cervix. The first patient is asymptomatic, singleton, no prior spontaneous preterm birth, 21 weeks. She resembles the cleanest short cervix progesterone evidence more closely. The number 22 millimeters places her in the short cervix risk boundary, but not in the strongest 20 millimeters or less recommendation zone. This is where shared decision-making can be meaningful, because the evidence gradient matters. The second patient has a prior spontaneous preterm birth. Her 22 millimeters does not live in the same probability space. Her history changes baseline risk. It also brings other management categories into view, some of them mechanical and outside this course. For medical treatment, we must not reflexively substitute one progestogen for another. Prior preterm birth alone is not the same indication as short cervix, and vaginal progesterone is not a replacement for withdrawn intramuscular 17-alpha-hydroxyprogesterone caproweight in a patient without a shortened cervix. This is the foundation. Phenotype first, timing second, endpoint third, treatment fourth. If you keep that order, the rest of the evidence becomes much easier to remember because every number has a place to live.